Okay, so let's talk about acute kidney injury. Acute kidney injury is, well, when you have acutely injured your kidney, and it's defined as an abrupt decrease in kidney function. And what's the function of a kidney? Well, to take in bad blood and filter all the waste, take in the good nutrients, take out the bad waste, and let only clean blood out to go back into your circulatory system. But if your filter is not working, then of course you're going to have buildup of toxic nitrogenous waste products, and you're going to have a bunch of electrolyte dysregulation. In fact, there's a criteria to diagnose this. We use the KDIGO criteria. So it's based on two things, the creatinine as well as the urine output. The creatinine must be 1.5 times their normal baseline, or within the past 2 days, there must have been an increase more than 0.3 in creatinine. Now, in terms of urine output, they have to have been oliguric, less than 0.5 milliliters per kilogram per hour in the past 6 hours. And when you have either of these, you diagnose them as having acute kidney injury because of the first stage. Now, the stages do elevate in severity based on the creatinine and the urine output. But as soon as you have this, you can classify them as having acute kidney injury. In the past, we've used other criteria such as the Rifle criteria and the Acton criteria. They slightly tweak the little numbers here, but overall, it's very similar to the KDIGO criteria, and this is what UpToDate recommends us to use currently. Now, for the clinical symptoms, as I said, you're going to have problems filtering and all that, but because you're in an inpatient ward and you're usually monitoring the creatinine and urine output, initially when you catch this, it's actually going to be usually silent, clinically silent. Nothing's going to be going on. You may be having some fluid overload based on some edema and hypertension, but other than that, there's not going to be a whole lot going on. So you have to think about the causes of acute renal failure. There's three real causes. There's problems before the kidney, there's problems at the kidney, and then there's problems right after the kidney. So in terms of pre-renal, you can think of blood usually flowing to the renal parenchyma, but if you have any sort of loss of blood flow, such as hypoperfusion, your kidneys are not going to work all right. And in terms of intra-renal, any sort of problem at the kidney, perhaps a toxin damaging it, or perhaps having a genetic defect can damage the renal tubules. That can also cause acute renal failure. Now, the last thing is post-renal failure. Any sort of obstruction after the kidney, perhaps in the ureter, bladder, or urethra, or even the prostate, can cause retrograde backflow of urine, potentially causing hydronephrosis, again damaging the kidney's parenchyma. So let's talk about pre-renal acute renal injury. So, as you would think, it's usually due to hypoperfusion, possibly in hypovolemic states. Usually, if you're thinking a cardiac problem, you're thinking a systolic heart failure. A systolic heart failure is when the pump is actually not working. There's not a lot of inotropy, so you're not going to have preserved ejection fraction. And if you don't have preserved ejection fraction, you're not going to go all the way down to your kidney to perfuse them properly. Now, on the flip side, if you have diastolic heart failure, it's a problem with filling, not with pumping. So you actually do have preserved ejection fraction. And therefore, you're probably not going to end up in pre-renal failure. But if you do have severe diastolic heart failure, pre-renal failure is also a possibility. Now, Hepatorenal Syndrome is something that we got a lot in UWorld, so it's something to keep in mind, and we can discuss this in a bit. And NSAID use and ACE inhibitors can also cause pre-renal failure, as we'll discuss soon. Hepatorenal Syndrome is really important, so why don't you take 5 seconds to think about why this syndrome exists, and we can move forward. Okay, so Hepatorenal Syndrome. The name says it all. The hepato, the liver, causes the kidney renal problem. Why does this happen? Well, let's say you have fulminant liver failure, such as cirrhosis is going on. This means that you're going to have portal hypertension. And you know that your portal veins feed into your splanchnic veins, which eventually feed into your heart, your kidney, your liver, and all this bunch of stuff. And your body always avoids trying to have hypertension. So to compensate, your liver releases nitrous oxide as a vasodilator material, which causes vasodilation in your arteries. This vasodilation eventually results in hypotension and hypoperfusion to the kidney, and this causes hepatorenal syndrome. One thing to note here is that this does not respond to fluids. In terms of NSAIDs and ACE inhibitors, we know that NSAIDs block prostaglandin production, and ACE inhibitors block ACE, which eventually ends in decreased angiotensin II production. So let's talk about what prostaglandins do. Prostaglandins usually increase and vasodilate the afferent arteriole, meaning blood coming into the kidney glomerulus. So that's all good. That's going to increase perfusion. And angiotensin II, whenever you're dehydrated, it's going to vasoconstrict the efferent arteriole, so you're not losing too much blood coming out of the glomerulus. Now, let's say if you have an NSAID. NSAID use is going to block prostaglandin, so you're not going to get that vasodilation effect. You're going to get some sort of vasoconstriction here. So first of all, you're not going to get a lot of perfusion coming into the kidney. And now, second, if you're also on an ACE inhibitor, you're going to be inhibiting the production of angiotensin II. You're not going to get this clamping down effect on the efferent arteriole. You're going to be essentially vasodilating your efferent arteriole, and blood is going to be easily leaving the renal tubule. That means less blood and hypoperfusion in the renal system. Now, there's also something called a triple whammy that you need to be aware of when you're in the inpatient ward. First of all, as I said, ACE inhibitors and NSAIDs can cause this pre-renal failure. But in addition to that, if you're also on a diuretic use, such as a furosemide, thiazide, or anything that's going to decrease the plasma volume and GFR, this, in addition to NSAID and ACE inhibitors, can cause significant pre-renal failure through hypoperfusion. So this trifecta of things is really important to be wary of. Okay, let's move on to when you're actually damaging the kidneys. Now, there's so many different etiologies of this: vascular, glomerular, interstitial. So I just really want to focus on a few of these. Vascular, you can have small vesicular vasculitises. You can have plaques and arterioembolic plaques that get lodged in the small vessels. Malignant hypertension, that's basically like destroying your renal parenchyma based on the pressure. And glomerular, you can have nephritic syndromes, which is based on proteinuria, as well as hematuria. Nephrotic syndromes based just on proteinuria, but still destroying the whole glomerulus part of the filtration part of the renal tubule. And interstitial-wise, you can have acute tubular necrosis, which I really want to focus on because it's the most common cause of interstitial renal disease. Acute interstitial nephritis, you remember the hallmark that if you take a drug and get a rash and hematuria and eosinophilia, you're probably going to have AIN. Other things is tumor lysis syndrome based on the urate crystals that can deposit there, and if you're on drugs like acyclovir, which can cause crystalline nephropathy if you don't drink enough fluids. But I really want to talk about acute tubular necrosis here because it's very important. Acute tubular necrosis really has two etiologies, either ischemic or nephrotoxic. Ischemic meaning you're having hypoperfusion and having ischemia, or nephrotoxic based on some sort of insult, perhaps an NSAID, perhaps a chemo drug or lead, something that basically damages the epithelium of the tubes. And once you damage the epithelium of the tubular cells, you're going to have these slough off the epithelial lining and bunch up into little casts. And these casts are defined as muddy brown casts on urinalysis. It also has high FeNA, but I'll discuss that a bit later. So, acute tubular necrosis, as we said, it can be ischemic. Now, where along the entire nephron do you think ischemia is most likely to occur? Well, it is definitely the proximally convoluted tubule as well as the thick ascending loop of Henle. Why do you think this is? Well, we know at the PCT and the TAL there is a lot of ion exchange. And where there's a lot of ion exchange, energy is needed. ATP needs to be made. And ATP is made, as you know, mostly in the terminal electron transport chain, where the terminal electron acceptor is oxygen. And oxygen comes from the bloodstream. So again, now you can think, if you're hypoperfused and ischemic, and you're not getting a lot of blood flow to the nephron, the most particularly affected places are going to be the PCT and the TAL. And now in nephrotoxic areas, what do you think is a very common antibiotic that causes this problem? Yes, aminoglycosides are one of the most common things. Vancomycin and other things do cause it. Amphotericin B is very common too, but aminoglycosides are one of the main questions that you get on Real World, which causes acute tubular necrosis. Now, what about any radiological technique? Well, if you have a CT scan that requires contrast, it can often cause nephrotoxicity. Other things can be lead, cisplatin, such as a chemotherapy drug, which also causes autotoxicity, like aminoglycosides, as well as myoglobinuria from a crush injury or rhabdomyolysis. So, in terms of acute tubular necrosis, there's a few stages. First, there's going to be the inciting event where you get ischemia or some sort of nephrotoxic injury. So, you've injured your lining, and now comes the maintenance phase. Once you've injured your lining, you're not going to be able to have those transport going, like the sodium reabsorption, potassium excretion. So you're going to have oliguria for a few weeks, and as well as hyperkalemia because of the electrolyte disturbances. But later on, as you recover, your epithelium starts to regenerate. You're going to have more urine production and hypokalemia as a result of compensation. Now let's talk about post-renal. Post-renal is the most mechanical part of this and is the very most easiest to understand. If you have any blockage after the kidney, perhaps in the pelvis, in the ureter, in the bladder neck, in the prostate if you're a male, or the urethral injuries, then it can cause obstruction. The thing to note is if you have something in the ureter, it must be both bilateral for there to be any sort of post-renal failure. Because if you have obstruction on, say, the left ureter, it's going to cause damage to this kidney. And this kidney can't actually, excrete out creatinine. But because creatinine is going to be built up in the blood and you have a regular kidney to excrete out the creatinine, you're not actually going to have any sort of 1.5 times baseline creatinine increase. And you're not going to be able to diagnose this person with acute kidney injury because they don't have it. So in terms of like ureter blockage, you need to have it bilateral, which is why post-renal failure in terms of ureteral obstruction is extremely rare. So let's talk about this whole BUN, creatinine, and FeNA business. It's important to know this so you can differentiate between pre-renal, intrinsic, and post-renal failure, particularly in acute tubular necrosis. So let's talk about BUN to creatinine ratio. When your kidneys are working right, BUN is blood urea nitrogen. It's a nitrogenous toxic waste product that you want to be eliminating from your system. Creatinine is something that you also want to be eliminating from your system. But we know creatinine is a measure of your kidney function because creatinine tells you that your kidney is working okay. If it's too high, it's not working right. In pre-renal failure, nothing is wrong with the actual kidney. It's just the fact that you're not getting enough blood into your kidney. So, if you're not getting enough blood into your kidney, your creatinine is still going to be okay. There's going to be no problem with this. But your kidney is going to sense that you're hypovolemic in a sense. You're hyperperfusing the kidneys. Your kidney is going to think there's not enough blood in the system. So it's going to release, renin-angiotensin, aldosterone, mediation, whatnot. But it's also going to reabsorb a lot of solutes. Another solute being BUN. Because where you reabsorb solutes, water follows. So you're going to increase your BUN for the reason you want water to be retained because your body thinks you're in pre-renal failure. So your BUN is going to increase, right? And your creatinine is going to stay the same, so the ratio is going to, of course, increase. Now, in the same fashion, intrinsic renal failure is a problem with the actual renal tubules now. So creatinine is going to increase in this case. BUN is probably going to stay the same because you're probably not hypovolemic or anything. So now creatinine increases, BUN stays the same. The ratio actually decreases now. Now, post-renal failure, it has a few two things here, but we can reason it out. In initial post-renal failure, nothing's really happening. You haven't had time to go back and cause renal parenchyma damage to the kidney, so it resembles more like pre-renal. But eventually, after a while, you're going to be damaging your renal parenchyma, and you're going to be looking a lot like intrinsic. And now, just a quick note on FeNA. Fractional excretion of sodium should be 1%. So pre-renal, nothing is wrong with the kidney, so it's 1%. But as soon as you damage the sodium transporters and the renal parenchyma, the sodium is going to be increasing, and it's going to be secreting a lot more because you can't reabsorb it because your kidney's damaged, which is why it's increased here. So as I said, acute tubular necrosis is the most common cause of intrinsic acute renal failure. Other causes are here, but mainly acute tubular necrosis. So in terms of evaluation, it really depends on the etiology. Of course, you want to get your creatinine, your urine output, so you can define it as acute kidney injury. BUN may be helpful to get the BUN creatinine ratio, but it's really based on suspicion. If you're thinking it's a post-renal problem, potentially it may be smart to get a post-residual bladder scan so you can see if there's any sort of bladder urinary retention. You can also get a biopsy if you're suspecting, based on clinical features, that this may be a glomerulonephritis or nephrotic syndrome. You can also get fluids if you're highly suspecting this to be in a hypovolemic patient for pre-renal failure. Now, in terms of the management, if you are in terms of an outpatient, you need to refer them to an emergency setting immediately if you suspect stage 2 or 3 AKI based on the criteria we discussed, or stage 1, and you're not sure what it's due to, and you're not sure how long the creatinine has been elevated. And now, if you are in an inpatient setting, you need to consult nephrology based on a few things. If your initial intervention is failing, you need an expert's advice. If it's any sort of glomerulonephritis with hematuria, you need nephrology. Or if the future of their treatment depends on some sort of consult, like chemotherapy, cisplatin we talked about can cause kidney damage, it's important to get nephrology on board. Now, the mainstay therapy of acute kidney injury is having some sort of thing that can replace the function of a kidney, which is really filtration. So we use renal replacement therapy as means to substitute as the kidney. This really means hemodialyzing the patient. So when do we use this? We use this particularly when the patient is fluid overloaded and has pulmonary edema, or if they have hyperkalemia, more than 6.5. Signs of uremia, hysterexis, platelet dysfunction, metabolic acidosis. This is an important one, pH less than 7.1, because if you've ever been in a code as a MS3, the first thing they give to the patient while you're doing compressions is, aside from epinephrine as a vasopressor, they give bicarbonate. They give bicarbonate because metabolic acidosis is one of the reasons that your heart can stop. And acute poisoning, of course, there's no way for you to actually get out the toxin from your blood, so you might as well replace it if your kidneys are not working. But unfortunately, in a hospital, this dialysis isn't immediately available most of the time, so you need to manage each of these as best as you can while you're biding your time for the hemodialysis to occur. So let's talk about hypervolemia with pulmonary edema. your kidneys are not working, so you're getting oliguria, and of course you're building up volume, and this can result in a lot of edema inside of your lungs, shortness of breath, hemoptysis. So the mainstay thing you want to give is furosemide. You want to give it in terms of IV fashion, starting at 80 milligrams once per day and building up as you need it. The goal is that you need to have a urine output more than 200 milliliters in 2 hours, in the first 2 hours of administration. Now, if this doesn't actually happen, you don't reach your goal, then you just go straight to renal replacement therapy because you don't want to be dealing with this. It can cause death. Now, severe hyperkalemia, more than 6.5, or if you have signs of hyperkalemia, which are muscle aches and cardiac arrhythmias, you need to go straight to RRT. But before that, while you're biding your time, you need to decrease the amount of potassium you have in your system. And the best way to do that, and the fastest way to do that, is through insulin, because it puts potassium into the cells. But in addition to insulin, always give glucose, because glucose, if you don't give that, you're going to become hypoglycemic with the excess insulin you're giving. And you want to give calcium gluconate because it can stabilize the cardiac membrane potential that hyperkalemia potassium can have an effect on. Kexalate is another potassium-binding resin that can help you eliminate the potassium. It's not better than insulin, but it's something to have on your mind in eventual renal replacement therapy. Here, if you potentially get an EKG while you have hyperkalemia, you're going to have this neat little peaked T wave, which is a hallmark of hyperkalemia. So just to go through the chart that UpToDate has in terms of treating hyperkalemia, if you have any sort of symptoms of hyperkalemia, immediately dialyze. If you don't, but you have more than 6.5 potassium, dialyze. But if you don't even have that, but you have the following three criteria, more than 5.5, you have renal impairment, or you have tissue breakdown, dialyze. Let's say you only have serum potassium more than 5.5. What do you do then? Then it becomes a little complicated that if you need surgery, then or if you have severe renal impairment. But mainly for our case, you really need to dialyze unless there's other features going on. Now, this hyperphosphatemia. Phosphate is usually excreted by the kidney, mainly by the way of parathyroid hormone. But if your renal parenchyma is damaged and your tubular cells cannot secrete out phosphate, you're going to have a buildup in phosphate. So you want to restrict this based on dietary phosphorus to less than 2 grams per day. You can also use phosphate binders like sevelamer if your phosphate is pretty high, more than 5.5, you're eating from your mouth, or you know that this guy's going to have a prolonged course of AKI. Hypocalcemia. This can cause muscle twitches and a lot of other bad problems with you. And the mainstay of treating this is actually treating the hyperphosphatemia. And this is because when you have a lot of phosphate in your blood, the phosphate is negatively charged and the calcium is positively charged. So phosphate actually ends up binding the free calcium in the bloodstream and lowering the calcium. So if you fix the phosphate, you're going to fix the calcium. But it's also important to note in this state, because you may potentially have a nephrotic syndrome causing proteinuria and changing levels of albumin, as well as having metabolic acidosis, changing levels of pH, calcium does depend on these two things. Albumin binds calcium, but in an acidotic state, you're going to have a lot of acid, mainstay H+. And H+ actually binds to albumin, which helps as a blood buffer to buffer the acidemia. But the binding sites get all clogged up with H+. So calcium is going to be more able to be free in the blood, and this is going to increase ionized levels of calcium. But this does not mean that you have total levels of calcium fixed, so this is something you need to keep in mind. Whenever you have uremia, urgent dialysis is important. Another thing from step 1, if we remember, if you have high BUN, this can cause nausea, anorexia, pericarditis. One of the main questions that I got that was pretty tough in your world was this guy came in, he had a crazy high BUN and creatinine, and he had chest pain that was relieved by leaning forward. And basically the answer was you need to do RRT immediately because he has uremic pericarditis. Another thing that people get tripped up on UWorld is platelet dysfunction. I had a question on UWorld that all it said was he had elevated BUN, elevated creatinine, and he was bleeding a lot after, say, a venue puncture. And the answer choices were all, what is increased? Is it PT? Is it PTT? Is it INR? Is it bleeding time? And it was bleeding time because it's platelet dysfunction. It's not a problem with the coagulation cascade, but with uremia, you have problems with platelets actually sticking together. Now, in a hypovolemic patient, of course, you would think you want to give fluids, and you'd be right. The fluid of choice is crystalloids at 75 milliliters per hour, about 1 to 3 liters. And this is really good for pre-renal failure because you're usually hypovolemic, and some intra-renal failures like rhabdomyolysis. Rhabdomyolysis is a problem when you have muscle breakdown, when you work out too hard, run a marathon, and are dehydrated. The myoglobin get into your bloodstream, which is toxic to your kidneys. And lastly, you want to avoid potential insults. The NSAIDs, ACE inhibitors, antibiotics, if you know those are the things causing nephrotoxicity, lower the dose or stop them, but also adjust for other medications like metformin, which if you have renal problems can cause lactic acidosis, life-threatening lactic acidosis, And you need to review the dosing according to the creatinine to assess the GFR. What that means, if you have a lower glomerular filtration rate, you need to decrease the drug dose. Because if you have your glomerular filtration rate decreasing, you're going to have a buildup in plasma, whatever the drug is. In this case, it's creatinine, but you could have an NSAID or something. So you need to make sure that you're not overdosing the patient. If you have metabolic acidosis, again, renal replacement therapy is the mainstay of treating, but in the meantime, you should give bicarbonate with a goal of this with a pH of more than 7.2. But you want to avoid giving bicarbonate in people who are hypervolemic. Now, why do you think this is the case? Well, it's the case because bicarbonate is actually given in the form of sodium bicarbonate. And sodium, if you give a bunch of sodium and salt into your blood, water is going to go in where the sodium is, and you're going to exacerbate the hypervolemia. Now, finally, in terms of prognosis, it turns out that if you get any sort of acute kidney injury, you actually have about a 20% chance of mortality, unfortunately. And of those people who don't actually die, about 5 to 10% actually never regain full kidney function and end up transitioning to end-stage renal disease. The chronic kidney disease risk actually increases times by a factor of 8.8. So overall, it's really important to understand the causes of acute kidney injury and make sure that you are understanding the etiology and treat it based on the etiology. The electrolytes as well as the fluids are very important, and hemodialyzing the patient is the mainstay of treatment for this disease. And here are the references for your future.